afternoon. Thank you.
So, Dr. Rahul Prasad, I will be needing your help because I am not seeing, and Dr. Vibhuti Bhushan also, I am not seeing Dr. Poonam Singh. She is the coordinator of the fishbowl glaucoma. So now we are starting our JHOS.
Ma'am, I've joined.
Okay,
Ma'am,
okay,
I'm
good.
there.
Okay. Actually, you were not receiving my call, so I thought you were not there.
No, I'm
Okay,
here. I'm here.
okay. So over to Dr. Poonam Singh. She's a very senior glaucoma consultant in the Tata Main Hospital, uh, Jamshedpur, and she will be introducing Dr. Sujata ma'am and Dr. Devendra. And first, we will take up the talk of Dr. Sujata ma'am because Dr. Devendra will join after him. Madam has a very beautiful presentation, case presentation. She will show cases. And okay, over to Dr. Poonam for introduction of both the faculties.
Hi, Poonam.
Hi, good evening, sir.
And then after their introduction, please introduce the chairpersons of this session and inner circle and outer circle.
Yeah, sure, ma'am.
Okay.
Okay. A very good evening, and we come towards the end of the session on glaucoma, which is a very important and very common topic also. So, I would first like to introduce our first master for the glaucoma, Dr. Sujata V. Kadambi, and she is a senior consultant in glaucoma services at Shankar Nethralaya, Chennai. She has completed her graduate medical education from St. John Medical College, Bangalore, and was judged as the best outgoing student of her batch. So she's a master in ophthalmology from Aravind Eye Hospital, Madurai, and she has done a fellowship in glaucoma from Narayana Nethralaya, Bangalore. She's a member and of the Associate Advisory Board for Young Ophthalmologists, Asia Pacific Glaucoma Society. She's also the recipient of Ruby Banik Award for Best Clinical Research in Shankar Nethralaya for the year 2022. She has several publications in peer-reviewed journals and has worked on glaucoma patient education projects. Area of interest include work on intraocular pressure and imaging in glaucoma. We are very delighted to have you today here with us, ma'am, so that our PG students are also will be benefited by your presence and your talk today. A very warm welcome to you in this session, ma'am. Uh, doc, Uh, and the next master speaker today is Dr. Devendra Maheshwari. I have met him because I was there for fellowship in Tirunelveli for short glaucoma fellowship. So he's at present an associate professor and ma'am. Still, he's in Tirunelveli Aravind Eye Hospital. He has done his long-term glaucoma fellowship from there itself. He's done his glaucoma fellowship from Bascom Palmer Eye Institute in Miami, USA. He has done his observership at various top universities like Long Eye Center, University of Michigan, Ann Arbor, Wilmer Eye Institute, John Hopkins University, Baltimore, and the New York Eye and Ear Infirmary of Mount Sinai. So he's a speaker of various national and international conferences. We have heard him many times, and he's a very good teacher also. More than 85 publications are there in national and international journals. Various chapters also he has written in various books, and he is presently associated with a number of national and international studies and research work which are still ongoing also. He was awarded as best glaucoma paper award in ASCRS, AIOS, GSI, all the conferences for that matter, TNOA conference in 2022 and 2023. He invented the first indigenously developed cost-effective mixed device, which is also named after his name, Dave Dualhook. So he's a member of various societies. He's a reviewer of various journals, and he is the person with whom you can associate for many publications also. So WGO and ARVO Travel Grant Award was awarded to him. His areas of interest are MIGS, which is the in thing now in glaucoma in Asian population, especially in angle closure glaucoma, along with emerging goniotomy procedures. So, very warm welcome, sir, to this session. We have been hearing you again and again for various topics at various levels. So, very warm welcome. We are very much sure that our students will definitely be very much enlightened by your talk today.
So please first introduce the inner circle and outer circle because we are taking the presentation of the postgraduate student first. And she is Pooja Tanwar from Bhagwan Mahavir Manipal
Yes.
Hospital. So please introduce the inner circle and outer circle and the chairpersons of the masterclass also. Chairpersons of masterclass also.
Okay, ma'am. The present Dr. Inner circle persons are Dr. Samiksha, who is from RI RIMS, Ranchi, Dr. MD Nasir Khan, RIO RIMS, Dr. Swati Kumari, RIO RIMS, Dr. Shweta Kumari, means from RIO RIMS. Then there is Dr. Amar Kumar from MGM Medical College, Dr. Mayank Sharan, and Dr. Vikas Thakur. They are all from MGM Medical College, Jamshedpur. And Dr. Bhavya, Dr. Raksha, Dr. Richa, and Dr. Sana Afreen, they are from our hospital in Tata Main Hospital, Jamshedpur. Dr. Lalita Priya Ji is from Gandhinagar Hospital, CCL Ranchi, and Dr. Nupur Gupta, Dr. Tushar Dhiman, and Dr. are from Bokaro General Hospital, and Dr. Anchit Pratik is from Kashyap Memorial Eye Hospital, Ranchi. And in outer circle, we have Dr. Anamika Chaudhary, who is from RIO RIMS, Dr. Vatsala Kumar, RIO RIMS, and Dr. Nidhi Sharma from MGM Medical College, Jamshedpur. Dr. Anamika Thakur, Bokaro General Hospital, Dr. Ujjwal, Bokaro General Hospital, Dr. Gagandeep Singh Gulati, Kashyap Memorial Eye Hospital, Dr. Shubham Singh, Kashyap Memorial Eye Hospital, Ranchi, and Dr. Ishad Khan, Kashyap Memorial Eye Hospital, and Dr. Pragya Chauhan, both from the same Kashyap Memorial Eye Hospital, Ranchi. So the presentation of the PGs is by Dr. Pooja Tanwar. The topic is bilateral pressure diversion, a case of marked intraocular IOP asymmetry post trabeculectomy. The time allotted is 5 minutes. So let's start with her talk. Should we take the master class otherwise?
Yes.
So, sir.
Pooja to aayi nahi? Yes, so take the master class first.
So the chairpersons for this session are Dr. BP Kashyap, who needs no introduction. Already, like we have discussed it many times. Still, he is the organizing chairman of the forthcoming AIOS midterm conference in Ranchi. He is the past president JHOS and ex member committee of AIOS. Dr. Deepak Lakra, who is professor of ophthalmology in RIO RIMS. Dr. Dharmender Kumar is the glaucoma specialist in Dhanbad Medical College and Hospital. Dr. Nitin Dhira, who is the chairman scientific committee of ISOC, and myself, Dr. Poonam Singh, who I am working with Tata Main Hospital in Jamshedpur. Dr. Anindya Anuradha is the head of eye department of Bhagwan Mahavir Manipal Hospital, Ranchi. Dr. Atma Prakash is the secretary of Dhanbad Ophthalmic Society. Dr. Shiril Sandeep Samaya is senior resident at RIO RIMS, and Dr. Amrita Srijan is the senior resident of RIO RIMS. So with all this, we finally go to the talk by Dr. Devendra Maheshwari on the Redefined GATT. Sir, over to you, please.
So you are muted, sir. So you are muted. Please unmute.
Yes, sir. So thank you, Varti Madam and Poonam for kind introduction. And can you see my slide, please?
Yes, we can see. Yes.
Right. Thank you. So good evening all. Today we are living in the era of the MIGS, really it transforms the management of the glaucoma surgery. So right now we look for the GATT. GATT is the most efficacious surgery. I think I will talk a little. Can you see my slide still?
Yes, we can see.
Yeah. So we look for the MIGS broadly divided into the based of the device-based MIGS. Really, they are really expensive, but the availability is again question mark, especially in country like India. They are the Gen implant, Hydrus micro instant, and eye stent. Though the eye stent and micro stent available in India, coming to the TM-based MIGS, that's called the GATT, Bang, Tanito micro hook, and my own hook, Dave Doll hook. They are readily available in very economic MIGS. So these are the how the glaucoma surgery developed over a period of time. We're not going into details. So coming to the here how the timeline and MIGS evolution in India. So the glucose, the one company really who is really responsible bringing the MIGS in India, and later on the Dr. Venkatesh, he is my mentor from the Aravind Hospital Pondicherry. Really he bring the GATT into the India in 2017 to 18. In between Dr. Grover come with the inventor of the GATT. They come to Pondicherry and teach us the GATT, and later on the GATT really become very prevalent in India and really one of the most efficacious MIGs in India nowadays. Later on the 1918 KDB, Bang and Hydrus, and we ever launched on new instrument very economic in the 2026. So always look about the India when you talk about the MIGs, really the cost is the biggest factor because we are the 75% of the population can't afford these instant-based MIGs. So you can look really the Bang, DDH, and the GATT. Really, they are the more cost-effective MIGs surgeries. Look here the impact of the GATT. If you look for the worldwide, there's more than 30 countries are practicing the GATT. If you look for the really big scientific, you look for the science. So look, this over period of time 2014 to 2026 initial period, you see the number of publications. When the number of publications coming, something that surgery is good or surgery is more efficacious. So what is the GATT? So GATT is the surgery in which the conjunctive procedure in which thus we cannulate the canal 360 degree by using the either catheter or by using the fibroproline. It is discovered by the Dr. Devendra S. Grover. So these are the gentlemen who is behind this surgery, Dr. Grover and Folman. And I'm fortunate to have learned with them. So coming to that GATT, really GATT, I previously told, GATT can be done by using the micro catheter. Really it is very costly, though it has a illuminated light. You can see the light all 360 degree. But again, this is a country like India and the low socioeconomic country, the catheter is costing the $500. It's difficult to afford. So the Grover come with the idea with using the same procedure by using the fibroproline that we talk in subsequent slides. So coming to the indication, really GATT has been originally designed for the mild to moderate POAG and selected case of the POAG cases, but by the use of the various country and by the practice of the various surgeons who are expert in MIGS, really it can be considered even in the complicated cases like juvenile glaucoma, pigmentary glaucoma, pseudoexpulsion glaucoma. Even some of the people can use in the angle glaucoma also. So there are three pillars of surgical process, how to do the surgery. There should be the right patient selection, right instrumentation, and right surgical technique. So I will come one by one. So the patient selection is very, very important. There should be patient neck mobility. There should be no head tremor. Patient should be cooperative and really angle visible in the clinic. And these are the various instrument is required, but I will summarize you really what we need extra for doing the GATT: direct gonio lens and low temperature cautery, fibroproline. Rest of the things you can adjust, or we need the micro tying forceps that we can use the retinal forceps with the max-ray forceps, or this a micro forceps what we used for this especially pupilloplasty, that forceps also can be used. The most important for any MIGS study, the patient bed should be above, so the head should be above the heart. That will help to avoid the reflex bleeding. Then any MIGS person, how we should do? We have to tilt the microscope 30 degree toward ourselves, 30 to 40 degree, and patient head should be go away from patient head should go away from you 30 to 40. Unfortunately, the video is not working. So main concept is there. Your scope should tilt towards you 30 to 40 degree, and patient head should go away from you 30 to 40 degree. And these are the lens, and these are the requirement we need: Swan Jacob lens. Then really we need the high density viscoelastic and fibroprotein suture. So how to hold the lens after putting the high density viscoelastic into the cornea? You have to place the lens. You can use any lens like Catina or Prismasex. This is the Swan Jacob gonio lens. This is called the docking of the lens. Then only you can view the angle, and this is very important. When you see the angle, there should be the in-fast view. So mean you can see the three-dimensional structure of the angle. Then you can perform the surgery in much better way. Now coming to the what the steps of the surgery, how you to do it. With most of the time with the phacoemulsification, so complete your phacoemulsification of the suture. So this is a 5 prolene suture, so measuring the length, and this will make a kink, so you have an idea how much suture has been passed. And after that, low temperature cautery has been used to blunt the tip. I can again repeat you here. So this is a low temperature cautery, has the blunt the tip. So after blunting the tip, there is additional this help of the MBR blade. You do the goniotomy first. After doing the goniotomy, the suture has been passed through the side port into the goniotomy side, and only 20 to 25 strokes are required to complete the 360 degree goniotomy. Once it comes, just you have to pull it off. Once you pull it up, you get the 360 degree goniotomy you can complete. And after the completion of the goniotomy, there may be some of the bleeding, so you have to leave some of the viscoelastic into the anterior chamber and keep your anterior chamber very tight and firm. So these are the steps of the GATT surgery. So again, I am showing the some of the example. Then this GATT, especially during the primary open-angle glaucoma, after completion of the phacoemulsification, we did the goniotomy. After doing the goniotomy, simply the way show you the last surgery, simple way, we have passed the suture 360 degree, and the suture had been pulled, distally pulled, and complete the 360 degree goniotomy. Similar way, the GATT can be done even the PSEG cases. Sometimes we need to do the goniosynechrolysis to visualize the angle. Then once we see the angle, we have to do the goniotomy, and the suture has been threaded to the 360 degree canal. And really, this is some of the cases well proven in the GOG cases, and some of the cases really very challenging cases like this where we can't see the angle. We can see, but I strongly recommend you have to be very expert in POG. Then you venture in such difficult cases, especially in PSEG. So I will be doing this first of the doing the synechrolysis. I am doing the goniosynecholysis, then making the neck. After once we got the neck, then we pass the suture. So it's not necessary in PSEG cases. You can once the suture, we are trying to pass the suture. You can see this is a PI, and really in such cases not necessary. You can able to pass in the 360 degree. Even you doing the 180 to 270 degree, it works well in certain situation. So the people really who is young novice surgeon, they want to learn the GATT. So the detailed video is available on the ISO video. Here we talk about how to do the GATT, what the precaution you have to take, how to start the baby step for learning the GATT. And look for the literature, so I don't waste much time because I think it's too late. So we look up the literature. We saw the 30 to 40% of IP reduction and significant reduction of the medication and effective in moderate to advanced glaucoma. So these are the various. This the meta-analysis shows that the GATT is the most efficacious MIGS in compared to any other MIGS. So this is the right now. Every time we even talk about the GATT, people ask the long term. Really, this is a new surgery in terms of long term follow up. So we have 4.5 year follow up, longest follow up, and we see there's a 40% of IP reduction, and this is a significant amount the IP reduction. Then come to India, when we talk about the GATT and MIGS, people ask you, what do you, these are Caucasian people with the foreign articles are the what's their own experience. So really we have our own experience. We published the outcome of GATT in the Indian population, where we did in a phaco GATT in one arm and phaco plain GATT in other arm, and really both arm are doing well. Then we go ahead further. We shown that there's a good efficacy in the Indian juvenile open angle glaucoma patient also. So these are some of the other articles where we see in the challenging cases also works well. And the recently this upcoming publication here we proved this 5-proline GATT. It works well in compared to POEG versus PACG. If you look for the here, really this works is results are comparable, and we compare this again the Tanito microhook and the GATT. Really we see this both are almost have the similar efficacy. So I think this is the last video I want to show you. This is the PACG case. Here we do the goniosynovitis. After doing the goniosynovitis, the goniotomy is done by MBI blade. You can go with the 26 gauge needle also. And this is a similar way we measure the suture. After measuring the suture, tip is blunted, and the suture, 5-proline suture has been passed through the goniotomy. It needs 20 to 25 strokes to come from the distal end. Once the distal end come, just try to pull off and you can get the 360-degree goniotomy. So this is I'm talking about this publication. So GATT is equally efficacious between the POEG versus PACG, and not only our study, there's a various other study are there, but they're the very early literature. There are only 4 or 5 studies there. They're showing the GATT has shown the good promising outcome in the PACG. Apart from that, Dr. Sikha also published that the GATT have the very good outcome in the congenital glaucoma, and this is a really 10-year-old child. When I did the 10 days old child, when I did the trap plus trap, but somehow I find that my cornea is clear. So other eye, I did the GATT in the 10-day-old child. And really right now it is a 2.5-month follow-up, and really the childs are doing good, and these results are comparable between the trap plus trap eye in compared to the GATT eye. So this here the typical atypical angle really have to master in the GATT, then only you can venture in some of the complicated or really little difficult cases. So we are able to do here get into the 10-day-old child. So these are some complex cases. Here we can also do the GATT, but I will strongly recommend we master GATT in the POEG, then only venture on the other. So like any other surgery, there are some of the complication, and hypema is the biggest challenge in the GATT surgery. They have the microhypema and macrohypema, so you have to take care of it. You have to leave your chamber very tight with using the 25% to 30% filled with the high density viscoelastic to avoid these complications. So the GATT has a really shows the very good efficacy, good safety profile as the economically efficient and versatile procedure. So just I will talk the 30-second more. Really the GATT is really clinically good result, but really have the steep learning curve. To overcome these results, you can start with the procedure like a bang, KDB, or the bang has the own drawbacks, like they have the fused and there's a needle is too sharp, and the KDB is very costly. So for that reason, we come with the new instrument. It's called the Dev dual hook. Advantage there really is a streamlined surgical process. It's very economic MIGs, not very much costly. It's single-handed. You can complete the bidirectional goniotomy. So just I will show you one video only. This is the Dev dual hook. It is the cutting is from the both side. So this is the PACG case. You can see here I'm doing the spatula to do the goniosynovitis. After doing the goniosynovitis, Dev dual has been introduced into the Slams canal. Once you go to the canal, just to glide it. Once you complete the other side, just remove from the other side. So this really instrument is similar to the Awarsinski chopper. So really muscle memory is there, and really is very easy to do even with the very novice, and it has been proved in the ACE OCT also. So thank you for patience listening. Any question, most welcome.
Thank you so much, sir. You make it sound so easy, but we all know that it is really the in thing. But it's definitely your last slide shows that it has a steep learning curve. But we everywhere this is the thing which is being talked about glaucoma recently. So, ma'am, Bharti ma'am, should we go for the next talk and then we'll take the questions together?
Take Dr. Sujata madam's talk, and then the Sakshi Tanwar will present. She thought that her presentation is tomorrow. So first madam's talk, and please Dr. Devendra, please stay connected, and I will request all both the glaucoma faculties to stay connected after their talk because of the fishbowl PG presentation.
Sure, sure.
Okay, madam.
Okay, so our next talk is by Dr. Sujata ma'am, and the topic which seems to be very easier, which is very difficult in the sense because that is the most confusing part, which will make easier the normal tension glaucoma, the diagnosis and management. So over to you, ma'am.
Thank you. Thanks, Dr. Bharti and Jharkhand Ophthalmological Society for this opportunity. Are you able to see my slides?
Yes, we can see, ma'am.
Instead of a didactic lecture, I prefer to have a few case-based scenarios, and I'll walk you through the diagnosis and management of normal tension glaucoma. I request the residents to please interact during the talk. Normal tension glaucoma is typical glaucomatous optic neuropathy with corresponding visual field changes and open angles in a setting of statistically normal IOP, which is IOP less than 21. So how do we arrive at this magical number 21? It is basically just the mean plus or minus 2 standard deviations of the population mean. But we know this concept is flawed because IOP is not normally distributed, but skewed towards higher values. The pathophysiology of normal tension glaucoma is little unclear and little complex, where it is multifactorial with IOP independent factors playing a larger role. Impaired blood flow, reduced resistance of the optic nerve head, vascular dysregulation, and systemic hypotension are all postulated and thought to be contributory to normal tension glaucoma. The disease prevalence in various studies varies from 24% to 32%. It is more common in the elderly with female preponderance. There are subtle differences between normal tension glaucoma and primary open angle glaucoma. In normal tension glaucoma, we can have a narrower neuroretinal rim for a given amount of visual field loss. The nerve fiber layer defects are more localized and closer to fixation. They could be acquired pits of the optic nerve, and disc hemorrhages are more common, about 2 to 5 times more common in normal tension glaucoma as compared to primary open angle glaucoma. Even the visual field defects which we get in normal tension glaucoma are more closer to fixation, deeper, and more focal. These patients tend to have nocturnal dip in blood pressures, elevated diastolic pressures. It may be associated with obstructive sleep apnea or vasospastic phenomena like Raynaud's disease. This is my first case. It's of a 67-year-old male, diabetic and hypertensive. The intraocular pressure on non-contact tonometry is found to be 14 and 17. Anterior segment exam is unremarkable. The fundus shows this damage like this. I hope the residents can appreciate the inferior notch, the superior notch and the nerve fiber layer defect, the nerve fiber layer defect in the left eye and inferior notch. So if you find a patient like this coming to your clinic, what are the investigations you would ask and how would you approach this patient? Maybe one of the residents from the outer circle can try. So my question is, you have this information with you. You have the NCT IOP of the patient, anterior segment exam with Van Herrig's grade 4, and you see that there is glaucomatous disc damage and corresponding visual field changes. So how would you take the investigations forward if this patient comes to your clinic?
Good evening, ma'am. Firstly, we'll talk about the 5 R's. That is the scleral rim, the neuroretinal rim, the RNFL, the peripapillary changes, and the retinal hemorrhages around the disc. And as far as the other finding is concerned, the VFA. Could you change the slide, ma'am? We'll after seeing the patient details and reliability index and false positive and false negative, which would be 13% and 33%. We'll go to the GHT, that is the glaucoma hemifield test, which shows that it is outside normal limit. Then we would see the mean deviation. Since mean deviation is there are three criteria. I mean, mild, moderate, and severe. So mild is mean deviation less than -6, moderate is -6 to -12, and severe is more than -12. In this case, the mean deviation is -10. So it comes to be moderate glaucoma, and the pattern standard deviation, the CPSD, is checked, and the total deviation and pattern deviation are also seen. And because after following the Anderson criteria, we'd come to the conclusion.
Okay, thanks, Dr. Vatsala. So you are right. So this is the information provided to you, and NCT IOP Van Herrick's grading, you're finding this damage and the corresponding visual field changes like how you correctly described, and it is fulfilling the Anderson's criteria. What I wanted to highlight is, for a diagnosis of glaucoma, just NCT IOP is not sufficient. Okay, and for diagnosis and managing a patient with glaucoma, we all know the gold standard measurement would be by Goldman applanation tonometry. So even this NCT has shown pressures of 14 and 17, something in the normal range. So before we initiate treatment for glaucoma, we need to do a day diurnal variation test or an office DVT, that is from 8 a.m. to 5 p.m. Every 2 hours, you will take intraocular pressure measurements so that you have a good baseline to know what is the actual peak IOP of the patient, and then the patient is having a lot of intraocular pressure fluctuations. Also, we need to document what is the central corneal thickness or the pachymetry of the patient. And most importantly, here I've only projected the information of Van Herrick's. Van Herrick's grade 4, it's not sufficient. No glaucoma exam is complete, or even a comprehensive eye exam is incomplete without doing gonioscopy. So you need to do gonioscopy to rule out occludable angles, to rule out any subtle pseudo-exfoliation. As I told you, normal tension glaucoma, you'll find the angles to be open angles. And also a very important fact for all of us to remember is, gonioscopy is not to be performed only at the time of initial diagnosis of the patient. We need to repeat the gonioscopy periodically, because as age increases, lens thickness can increase, so then the angles can get narrower. And whenever a patient has unexplained progression, you need to revisit the diagnosis and repeat the gonioscopy to recheck whether you label the patient correctly as open angle or normal tension glaucoma. So normal tension glaucoma, remember, is a diagnosis of exclusion. So these are some of the salient features you need to elicit in the history. You need to rule out secondary causes of one-time damage to the optic nerve head, and other systemic associations which I described. Okay, so this is another case in front of you. It's a 72-year-old male with a right eye normal tension glaucoma, advanced this damage, and visual fields progressing in the right eye, and the patient is on one medication, a prostaglandin analog in the right eye. Since the patient is already on treatment and the visual fields are progressing, the next step for you to logically think is to see if the patient is having a lot of intraocular pressure fluctuations. If that one clinic IOP visit is IOP reading is not picking up the peak IOP, so you're subjecting the patient to a day DVT, and you find it in 10 to 12 millimeters range, which is kind of an acceptable range. The patient also had ischemic heart disease and was post angioplasty with stenting and benign prostatic hypertrophy and selective alpha-1 antagonist. Retrospective history taking, the patient gave a diagnosis of sick sinus syndrome. So in this case, we subjected the patient to further cardiac evaluation. Because of his sick sinus syndrome, we subjected him to an ambulatory Holter monitoring, and it was found that at one point in the night, the heart rate dropped to 37 beats per minute. And ambulatory BP monitoring for this patient showed that he used to have a nocturnal dip, or blood pressure also dropping in the middle of the night. Carotid Doppler showed a 20% stenosis in the external carotid artery. So this 20% stenosis may not be considered hemodynamically significant by the cardiologist, but considering that this patient has advanced disc damage, normal tension glaucoma, has other cardiovascular morbidities, and is progressing, we need to communicate the importance of this finding to the cardiologist, and they would probably consider starting the patient on an antiplatelets and following up and repeating even the carotid Doppler more periodically. So this is a third case in front of you. It's a 72-year-old male, normal tension glaucoma, advanced disc damage in both eyes on 3 medications, and visual fields are progressing. Again, the first thing we want to rule out is whether it is because of an IOP factor. Day diurnal variation shows that it is between 10 and 11, quite kind of acceptable. Basic cardiac evaluation, the ECG, echo, carotid Doppler doesn't show anything abnormal. The patient also gives a history of snoring. Considering this history of snoring, we subjected the patient to an overnight sleep study and found that the patient had an apnea-hypopnea index of 33:2, which is severe obstructive sleep apnea. So in this case, it was not the intraocular pressure which was caused the worsening of the glaucoma, but the associated obstructive sleep apnea, which is also associated with impaired blood flow to the optic nerve head. So this patient improved with weight loss measures, sleep hygiene, and a CPAP therapy. This is case 4. So you have a patient like this, 56-year-old male, day DVT in the range 12 to 14. Elsewhere, he's been started on 1 glaucoma medication. The disc looks like this and the visual fields look like this. Can any one of the residents from the inner circle describe the disc for me? Or anyone from the outer circle as well? It's open to the house. Can you describe the disc and you tell me if the disc and the visual fields are correlating, and what would be your next approach? What other investigation you would ask?
Vatsala, Anamika.
Well, ma'am, the disc findings does not match with the RNFL. I mean the VFA.
That's lovely. Yes.
Yeah, it could be a disorder in the visual pathway. So we'll go with the MRI also to see whether there is a tumor or something.
Excellent, excellent. So what are those? Dr. Vatsala pointed out correctly. So here you see it is more of like, say, I would describe that this is 0.7 with sloping rims, pallor more than cupping. Okay. And here the visual field defects respect the vertical meridian. So these are mimickers of normal tension glaucoma. So and what are those conditions when your patient walks into your OPD treated elsewhere as glaucoma? When would you consider to do neuroimaging? When the patient is young, they have new onset symptoms, pallor is more than cupping, it's very highly asymmetric cupping, the disc and the visual field defects don't corroborate, visual field defects are respecting the vertical meridian, and there's sudden rapid progression. Glaucoma is a very slowly progressive disease. So whenever there is a rapid deterioration in the patient in terms of the visual field, you have to go back, look again at the fundus exam. Have you missed any vein occlusion, or think in terms, neurological terms? Okay, very good, Dr. Vatsala. This is another patient in front of us. It's a 67-year-old female, normal tension glaucoma on prostaglandin analog. Previously, this patient has had very stable visual fields, and suddenly you have this kind of clinical picture. So what is this feature you see in this clinical picture, and what would be your next course of action? Can anyone else from the outer circle try?
Ma'am, there's a splinter hemorrhage there.
Yes.
So this is a splinter hemorrhage in case of a normotensive glaucoma has high chance of getting converted to a primary open angle glaucoma.
You're partially right. Okay, it is a sphincter hemorrhage, splinter hemorrhage. It's also known as a Dran's hemorrhage. These hemorrhages are associated with worsening. So in this case, what are the things you would think of? You will think if the patient is worsening, you want to look for any IOP fluctuations. So you will document a day office DVT or a day diurnal variation test.
Yes, yes,
It could also be because of blood pressure fluctuations. So you will ask the patient to go back to their physician and monitor the blood pressure at multiple times of day, because that can also vary with activity and time of the day. You will document a stereo disc picture like this for you to follow up the patient in the future, apart from the basic visual field test. And although this patient has been stable, probably you were following up this patient at 6-monthly intervals or an annual checkup. Now, if everything else is normal in your this evaluation which you have done, you will consider following up the patient more closely, maybe in 3 months' time itself.
3 months.
Okay.
Yes, ma'am.
So it's important to remember that in IOP reduction in cases of normal tension glaucoma, we prefer prostaglandin analogs because that helps to blunt the diurnal IOP fluctuations better. We will avoid beta blockers because that can cause a nocturnal dip in the blood pressure. Alpha agonists are a second line. They also have a postulated neuroprotective effect. We could then consider carbonic anhydrase inhibitors, which have a postulated, they cause improvement in the ocular blood flow. Also important to identify and treat any cardiovascular disorder. We will consider surgery in case there is progression of the visual fields, despite all other factors investigated is being taken care of and that is under control, because it is finally surgery which helps blunt diurnal fluctuations best. And when we consider trabeculectomy in these eyes, we prefer to use low-dose mitomycin, multiple releasable sutures, so that we can titrate the eye pressures post-op. And it's also extremely important to take precautions to avoid hypotony. Okay. So this is another case in front of us. This is a 73-year-old male, normal tension glaucoma, showing rapid progression. You can appreciate this on the GPA, which I put on the right-hand side, okay, on 3 medications. Post-trabeculectomy, the left-hand side GPA shows that the visual fields have all stabilized well post-trabeculectomy. So the take-home message is normal tension glaucoma is a continuum of open-angle glaucoma. Here, the non-IOP dependent factors or the vascular factors play a greater role. Always confirm the diagnosis with a gold standard Goldman applanation tonometry IOP reading. Do a diurnal phasing. One IOP, you cannot label a patient as glaucoma, and before initiating treatment, it's best to establish what is the peak IOP, what is the IOP fluctuations. Always do a gonioscopy. Repeat the gonioscopy periodically. Exclude secondary causes or causes which can cause a one-time optic nerve head damage like trauma, like massive blood loss, long-term steroid use. Do refer to a physician for cardiac evaluation, nocturnal hypotension, or sleep apnea as and when applicable. Prostaglandin analogs are preferred. Avoid beta blockers. And when trabeculectomy is needed, take precautions to avoid hypotony. Thank you all. I'm happy to take questions if there are any.